everybody. I'm Dr. Meenakshi, one of the mentors at StudyMRCOG, and this is the Back to Basics series wherein we are discussing module-wise. I hope you have watched the previous videos which have been made on different modules. If not, please go and check it on the channel, which is already live. So today's module is going to be about postpartum problems, and as we always start off with a quote, and the quote for today is going to be, don't let a bad day to make you feel like you have a bad life. So we'll be seeing like how do we approach this module and what are we going to cover today. And I'll also be covering about 2 or 3 cases, just a brief discussion about the cases which can, which is a possibility. So there are a few do's and don'ts for this particular module. So in the postpartum, it is both maternal as well as the neonatal, but mostly you will be given about the maternal only. And even if it is like neonatal, it could be like neonatal resuscitation, and which could come like a teaching station, or sometimes you have to just brief the parents if there was any neonatal sepsis. It was also one of the possibilities, but mostly it is going to be on the maternal side only, where there are a lot of cases. So firstly is you need to be very, very sensitive and very empathetic, especially whenever there are cases like intrauterine fetal death. So whenever there is intrauterine fetal death, there are different possibilities to this. Either she has had an intrauterine fetal death and you're here to discuss about the mode of delivery, and or sometimes she's already delivered and you're going and meeting her in the postnatal ward, wherein you're going to be discussing with her about the postmortem examination if required, and how is she coping and all of that. That is also one of the possibilities. Or the other possibilities that she is coming to you at 6 weeks postnatal and she's come to you with the postmortem report or with the other investigations when you're going to discuss with the woman about the same. So instead of like directly diving into the station, it would be better that firstly you're very empathetic and very sensitive and just ask, I'm really very sorry to be meeting you in this position. I'm aware of your condition. I'm aware of your loss. How are you and how is your partner coping with it? I'm so very sorry. I know it must be very difficult for you. Okay, you can avoid using the phrase called I can understand. Rather, you can say it is understandable, or you can say I know it must be difficult for you. You could use these sentences rather than using that I can understand. So there could also be one of the cases like dyspareunia. She's coming to like after delivery and she's coming to with dyspareunia. So you need to be very sensitive and you need to discuss with her what could be the different possibilities, starting from lack of interest to maybe breastfeeding to probably there could be a thickened scar, wherein you're going to explain about all of these. And so it's very important that you don't be judgmental and you be very, very sensitive, especially when you're exploring that area. And you need to be very honest. That is something which we call as the duty of candor. For example, that there is a retained swab. There is a woman who has delivered vaginally, or maybe she had a perineal tear or just a vaginal delivery, and following that, she comes back to you after a week or 10 days that, when she was showering, she noticed something, and that is actually a retained swab or a mop. So how are you going to speak to her is very, very important. You should not jump to conclusions, or if she's telling that probably there was another doctor who didn't know how to deliver and the doctor has left the swab inside me, you should go in a non-blame manner rather than saying that yes, maybe my colleague has done this. You should not do that. Instead, you have to just acknowledge whether she's worried whenever she's worried, and say that I'm really very sorry, your anger is justified, and I want to tell you that this is a never event. It shouldn't happen to you, or it shouldn't happen to anyone. And everybody in the NHS is trained, and only until they're signed off, they won't be assigned any case with the patient, or they won't be allowed to perform any procedure. But this is a serious matter, and NHS would take such things seriously. And we'll be investigating, and once we get the results, we'll be in an open and an honest manner. We shall be discussing with you, and I'm really very sorry about that. And you should be interested in her health, that you'll be prescribing a course of antibiotics to her, because that's a retained swab, so it's a source of infection. So you have to tell her that in order to avoid any long-term complications, yes, definitely we'll have to be putting her on a course of antibiotics. So you have to say that your health is a priority, and then you can maybe ask about the baby's name and if she's breastfeeding, because she cannot get angry when you're asking about your baby's name, is it not? So you can just ask in that way, and you can get the station under your control. And rather than being defensive that this has happened, or maybe this is not a fault or something like that, rather than doing that, make sure that you acknowledge whatever she is feeling, and then you can go ahead and explain about what are we going to do further. And in a postpartum woman, it's always important that you need to inquire about her general health, and that I'll be discussing shortly. And there are 5, or we call as 6 B's that we need to discuss with any postpartum woman. That is, we ask about her baby and about the breastfeeding as well as the bonding with the baby, and then you also ask about her bowel as well as the bladder movements, and about her bladder habits, and also we ask about the bleeding as well. So it is important that to any postpartum woman, do not forget asking about these questions which are related to this 5 B's. And you should also address about contraception, which is an extremely important point where candidates can forget addressing about contraception to any postnatal woman. So if she's coming to and if she wishes to discuss about any about the contraception, do not impose that this is the best method, or this could be not suitable, or this is not good, or this is good. Of course, you will be telling like what could be the failure rates and which is not suitable, or which is usually for looking at her comorbidities, etc. You may tell her like which is going to be the better option, but do not decide for her. Okay, you can always give the choice, and you always give the outline what is given, and of course you will definitely be telling about what is going to be suitable for her, but do not impose any decision. It's her call and she can decide. You have to just tell about the benefits as well as the risks which are associated with that method of contraception. I'm saying, for example, as a contraception for that matter, in any of the case, it would be better that you don't impose any decision. So give her the outline and tell her that this could be the benefits and risks, and then she gets to decide which is going to be suitable for her or which she prefers. And never forget about the clinical governance part. For example, if there is a perineal tear, it is important that you have to raise an incident report for the same, and you have to be very open and honest that that there is a tear which has happened, and what are you going to explain to her about the further perineal care, and about regarding the future pregnancies, and regarding the red flag signs. When you tell about everything, you have to make sure that everything should be documented in the notes in a very clear manner, in a stepwise manner. Duty of candor needs to be performed. You need to apologize to the patient, and this is something which is an integral part, of course, of all the modules, not just restricted to postpartum, but do not forget to involve the clinical governance part. So we'll be seeing as in how do we prepare, and what can we expect, and what to do and what not, which we have already done. So as I have discussed about the B's in the first, in the beginning itself, that you should not forget about all of these in any postpartum woman. So here we have got different the domains. You could be tested, of course, all the 5 domains would not be tested together. You could be tested either on 3 or on 4, but it's important for you to know what would be tested under each module, under each domain. So in the information gathering, of course, you will be asking about the 5 P's, which I have just told. And very, very important point is to assess for her mental health, because in any postpartum mother, it's important that you need to ask about how is she feeling lately, and how is her mood, and how is her bond with the baby, and is she comfortable, is she feeling anything weird or anything unusual. You can ask about that, because this is the time we also screen if she's got any mental health issues. And of course the BMI and allergies and medical history, allergies as well as the surgical history, this is all very, very important, of course, which we take in any case. And it's important that you need to take about the antenatal history as well as intrapartum history, so that you get to plan her a safe postpartum care. For example, if she sustained a wound infection, a perineal wound infection, or maybe it could be like a post-cesarean, she's come to you with a wound infection, it's important that you need to take the entire history, so as to understand like what could be the source, or if there is any risk factors that has probably contributed to this. Or let's say she's come to you with a vaginal discharge postpartum, it's important that you need to also explore the other risk factors which could be probably contributory, if it is chronic, or whether this is the first episode. To know all of that, it's important that you need to take all of the history. And sometimes they could also come with the perineal wound infection as well. So when they're coming to you with the episiotomy wound, which could be a delayed healing, so you need to explore about the intrapartum factors, like whether there was any prolonged membrane rupture, or whether there was a prolonged labor and delay in the labor, and which could call that there could be probably multiple examinations which could act like a source of infection. So it is very important that you need to take the entire history after you ask about the general well-being of the woman. And communication is, of course, you need to greet and introduce. This could be like two kinds. Either you're in the postnatal ward, wherein you directly introduce yourself and introduce with the patient's name. Like you say, hello, I'm Dr. Meenakshi, one of the doctors in the postnatal ward today. Am I speaking to? You have to address with the patient's name because she's inpatient with you. So you do not ask what is her name. And the second part to this is probably she's coming to you at 6 weeks postnatal or 4 weeks postnatal, just come to you for follow-up. In that case, of course, because you're in the clinic, you ask her by confirming her name as well as age. So in the ward, you address directly by the name, but in the clinic, you ask for her name. And you need to build rapport and fix agenda for the station. That is extremely important, that you need to fix an agenda. If it is already given to you, you need to fix an agenda. But otherwise, you can just ask me, I know, how can I help you today? Or what are your concerns? And what are your expectations from today's consultation? You could put it that way. Maintaining eye contact is very important. And they also would give certain non-verbal cues. That is probably they're not feeling good, or maybe they're sad. They could just show it with their expressions, which you need to catch. And always, whenever you're trying to maintain eye contact, when you're talking to a patient or to anybody, it shows how confident you are. So make sure that you maintain good eye contact. And of course, you need to be very empathetic, especially if she's sustained any complications, as we've just discussed, or if it's an IUFD, make sure that you express condolences at the very beginning of the station. Just say that, hello, I'm a doctor, and then I'm really very sorry, I've gone through your notes and I'm aware of your loss. You could just put it that way, so that you're just calming her, and do not act as if you do not know anything and just asking like what is there and what is bothering her. Instead of asking those questions, you can just address directly, because you already know that she's gone through something. So make sure that you acknowledge it. And having a patient listening is very, very important. And never ever cut the role play. When she's giving you a big history or when she's talking a lot, please carefully listen to her and acknowledge it, and then go to the next question. Supposingly she has told about a big story, let it be related to any incident, and she's told everything, and you just listen to that, and then you say, okay, do you visit a GP regularly for any condition? That's not the way. You need to sit down, just wait for 3 or 4 seconds and just acknowledge. If you're saying something, a tragic story or something which is sad, then say, I'm really very sorry to hear about this. How are you coping with it? Okay. Or you can say, oh, I can see how where your concerns coming from. Okay, just like that, you could just tell in that way, so that you first acknowledge. Otherwise, your station might get disturbed. So be very, very careful and try to acknowledge, patiently listen to her, and let her talk as well. And when she's talking, make sure that you give adequate pauses, given some time, let her react, and then you can go ahead. And you should not be appearing like you're just rushing into the station, because everybody's got the same 10 minutes. There could be one candidate who's probably giving some pauses and making the patient comfortable, then and probably going ahead with the station. That way that candidate could score better, rather than the one who is trying to rush and trying to finish all the domains and trying to finish the information gathering and etc. So make sure that you stay calm and let the station go smoothly, and let it go with the flow, rather than with the intention that you have to complete the station. And you need to be very, very open, and you need to be honest about the complications, whatever it could be. Even if there is any shortcoming from our side, if there has been an error from our side as well, make sure that you have to go and apologize, and you need to be honest. Suppose there could be a missed dose of an anticoagulant and she's landed into a venous thromboembolism, or as we've just discussed regarding the retain swab, you need not beat around the bush, or there is nothing that you need to cover up. It's very important that you have to be honest and you be open, and then tell her that you will have to raise an incident report wherever required, and then you can go ahead with that. And you can be tactile if applicable. That is, you can just touch the patient when she's just crying. Just you can just pat her and say, I'm so sorry, we are here with you during this journey, please don't worry, we are here to help you and support you. Just that way you could put. And when she's telling something, if she's crying or if she is happy, make sure that you validate it. If she's saying that my baby's name is Lisa, then you can say, oh wow, that's such a lovely name. Just you could put it that way, right? So if you're acknowledging it, whatever it could be, happy, sad, or if she's angry, make sure that you have to validate her emotion, because she's putting out something. That is what we do in our clinics as well, right? When you're talking to a patient, and when she's sometimes they could be just tearful when they're telling about the story, but probably they'll be very happy. It's narrating about something which has happened to their home, and we'll just react to that, right? It's like how you react to a normal person. Make sure that you have to validate that emotion, and you can just, when she's talking to you, make sure that you nod your head appropriately, like whenever required. Doesn't mean that you keep nodding every time. Just keep nodding and say it should be in a way that you are following what she's telling. and that you are listening to her attentively, and that you're paying attention to her. So definitely she's going to, be satisfied with you. And of course, to give the patient information leaflets at the end is very, very important. And you need to be having the ability to tackle these sensitive issues whenever there is an IQFT, or if there is any other complication for that matter. You have to be very, very sensitive rather than becoming defensive. Make sure that you mellow down your tone a bit, at least one step down your tone, and then you can go ahead and talk. That could make a big, big difference. Communication with colleagues is, of course, will be involving the midwife, the GP, the neonatologist, the counselors, physiotherapist. Suppose there's a perineal tear, it's important that in that cases, especially, that she has to regain the strength of the pelvic floor muscles. And in case of any infections, we'll be sending it for culture and to choose for the antibiotic. And of course, we'll involve the microbiologist as well. Perinatal mental health specialist, very important. In certain cases, we might have to refer in case she's got any bipolar disorder, she's got any severe mental illness, or if she's presenting with a few symptoms. But yes, if there is a first degree family relative who's been probably affected by any disorder, or if she has had any antenatal issues, or even prior to the pregnancy, if she's been having any complaints, and now that it's getting worsened, then of course will be, and if she's on any complex medications, psychotropic medications, we need to refer to the perinatal mental health specialist, which is an important aspect. And of course, we'll also be putting to the nurses who's going to help her with the breastfeeding. And prescribing safe medication is very, very important, that you need to rule out allergies before you prescribe any medication. And as we have just discussed about the clinical governance issues as well as safeguarding issues, extremely important. And psychological morbidity is something that you need to assess as well. And suppose if she's lacking any support at home, make sure that the child is safe and she's also safe, and you need to acknowledge her safety as well. And of course, coming to the applied clinical knowledge, we need to follow all these standard guidelines that we have been following. And you need to be able to understand how do you manage that particular case. And even if you do not know anything about a particular case, and if it's a complete new station to you, please do not panic, because you're being tested on 3 or 4 domains. So even if you're greeting properly, and if you're talking to her properly, and if you're acknowledging her concerns, then definitely your communication with patient domain is going to get ticked over there. Although your applied clinical knowledge might be affected because you are not aware of what are you going to talk, at least you can involve the MDT, and your communication with colleagues also is going to be ticked over there in case it is being tested. Patient safety, of course, you'll be acknowledging if she's got any allergies, or when you know that there is a particular contraindication, of course, you need to be aware about that. So definitely, if you're going domain wise and if you break that station down, it's never going to be a problem to you. And of course, the information gathering, as we all know the routine template. If you do not know any new station, please do not panic. Just stay calm and go ahead and just keep asking questions. You might get clue at any one point, so that you can take your station forward from there. So what are the different cases scenarios that you could expect? And they could be perineal tears, and she has sustained a tear and the repair is already done, and you're there to explain about the perineal care and what are you going to do, everything. And you ask her to come for the follow-up and etc. You ask her about the pelvic floor exercises, the perineal hygiene, and you have to check her on medications to make sure that that she's put on laxatives and antibiotics and analgesics required. I'm sorry, you need to look into all of that, and that's when you'll be discharging the patient. And there's also, or probably it could be that she had sustained a perineal tear before, and in this pregnancy she's come to discuss about the birth plan. That is also one of the possibilities. And IUFD, as I told you, it could come in different possibilities. Mental health, extremely important. Blues, depression, or psychosis, anything. It could come as a structured discussion, or could be an SPT as well. Based on her symptoms, you should be able to identify whether she's in blues, or whether she's in depression, or whether it's a psychosis. Postpartum urinary retention, again, another fancy question, which is very important, and you need to be well versed with the flowchart of the urinary of the postpartum voiding dysfunction. And of course, they could come to you with wound infections, any cesarean wound infections. They could come to you with episiotomy, gape, or they can also come to you with any wound hematomas. So this is also like one of the possible questions. Retain swab, postpartum hemorrhage. This PPH could come either in the form of teaching station, where you're teaching your junior about the PPH, or it could be a structured discussion on PPH, or it could be like an SPT as well. So it's important that you need to explore the risk factors and everything. If this mostly fits into a structured discussion, there is a possibility. So make sure that you are thorough with the guideline on the postpartum hemorrhage. Maternal collapse, again, yes, can be a structured discussion. And then now we've got the postnatal ward rounds, which is very similar to the pre-op ward rounds. But what are we going to say in the postnatal period is, of course, going to be a bit different. But of course, we have just discussed about all of the symptoms and everything which you're going to inquire. And pulmonary embolism, all of this is, again, the clinical governance part of the delivery, after the delivery, which could be possible. And we're going to be discussing very quickly about just few cases. And firstly is about the mental health. This is one of the very important questions for blues, depression, and psychosis. You need to understand about what could be the symptoms. Having low mood or lack of interest, and all of these could be common symptoms, but there are certain specific symptoms that you need to be aware of in the blues, depression, and psychosis. And of course, blues is something, they'll be getting easy irritability and mood swings, and they become very easily tearful. And usually that subsides by the time the child turns 10 days old. And all this requires us only to have good support at home and doesn't require any treatment. And then, yes, you've got depression. In this, they'll be having a lot of symptoms like lack of appetite, feeling guilty, negative thoughts, or they can get suicidal thoughts. And this is very rare that they can harm the baby, but it depends. They might have interest, they might not have interest in baby, they might have interest to feed the baby, or they might not like. So it depends. And sometimes when they're landing into severe depression, that is something that it's really important. They might develop these psychotic symptoms. So we need to be aware of all of those. And it's very rare that they usually do not harm the baby in the postpartum depression. So of course, we'll be giving the talking therapy, the cognitive behavioral therapy, and antidepressants if required. But as an ST5, we don't do that. We need to escalate the case to the specialist, who is going to be starting her on medications if required. And of course, we have the puerperal psychosis. Puerperal psychosis is a psychiatric emergency. Okay, they present with hallucinations, they present with delusions. Okay, when you see those words, it indicates that she's going into a psychosis. So very important that, you'll have to be admitted to the mother-baby unit, and we need to make sure that proper care is being given to her. And they'll be putting her on the cognitive behavioral therapy, as well as mood stabilizers could be added. It depends upon her condition. Based on that, the treatment could be decided. And it's very important that whenever they're presenting to you with these conditions, it is important that whether she had such symptoms during the pregnancy or even before the pregnancy, if she had any such disorders, or most important is about the family history, if she's got any, or previously was she taking any psychiatric medications. This is the history that you should not forget in case she's coming to you. And this is one of the examples for the postnatal ward round. So there is a 36-year-old para 3 living 3 who delivered vaginally about 6 hours back, and she has is a known case of chronic hypertension, and she's on methyl-dopa 250 milligram TID, and her BMI is 32, vital stable uterus well retracted, and PV, there is no active bleeding. So obviously in the postnatal ward, what are you going to do? You need to look for her general well-being. As you already know that the observations and everything are stable and the uterus is well retracted, you can ask about the baby, like how is the baby doing? Has she initiated the breastfeeding? And has she given the first feeding, because it's almost 6 hours back, right? And is she able to eat and drink? You just ask about her well-being. And now you can see that her BMI is high, and also she's 36-year-old and she is para 3. So all of these will be calling for risk factors for venous thromboembolism. So therefore, we'll also be discussing about the low molecular weight heparin prophylaxis as well. And since she's on methyl-dopa and she's chronic hypertension, you can discuss with the specialist and go back to the pre-pregnancy medications, which is important. And also methyl-dopa is known to be causing some postnatal depression. So make sure that, probably we can just change her medications. But as an ST5, we don't take any self-decisions. That will be done only after you take the inputs from the specialist. And since she is a case of hypertension, it's important that she has to come back for the follow-up, so as to review how she is doing. So this is about the venous thromboembolism chart, and it's very important that you need to understand what could be the risk factors, whether it is antenatal or whether it could be postnatal. See, for for certain conditions, it is important that you need to understand, because you will have to be counseling the woman that she'll be started on heparin, until when she'll be continued on heparin. You have to tell all of those points, and if it's a structured discussion, then yes, you will have to be knowing all of those details. So it's important that please go through all of these charts once before you go for the exam, so that you can answer with much more confidence. And another case is about a post-cesarean with wound infection. She has come to you with suture infection. So obviously she's going to be angry, and she waiting for your consultant, so apologize for the same, and then you go ahead. And if she's telling you that I've got this wound infection, you can say, may I ask you a few questions? That won't sound good. Make sure that you firstly acknowledge what she's doing. I'm so very sorry. I know that it must be very difficult for you being just delivered and having this infection. Definitely you would be affected by that, but I'm very sorry about the same. Please don't worry. Whatever it is, we are here to help you and support you. you can tell that acknowledge just about 10 seconds, and then your station would go very smoothly. And if she's telling that, I've got wound infection, then you say, okay, let me, ask you a few questions. First, you acknowledge that. And then you go for the questions. Otherwise, if you're directly going for the questions, that might not sound good. So firstly, acknowledge and then say that before I can know as in why this infection has happened, it is important for me to understand and know more better about you since we're meeting for the first time. Would that be okay? And then you ask about the risk factors. If she's got any prolonged labor, and then was she posted for a cesarean section? Did she have any ruptured membranes, or did she have any anterior risk factors, let's say, for example, any anemia or any diabetes? Okay, you need to explore all of these risk factors. And BMI, very important, okay, which could possibly be one of the reasons, is it not? So you need to explore all of these risk factors and then generalize and say that in women, we see that in women who has got, lower blood levels, or when the strength of the hemoglobin or the strength of the blood is low, or we see that in women with slightly higher weight to height ratio, there is a possibility that there could be some infections. And then you manage her, tell her that we'll be putting her on antibiotics and we'll be doing some regular dressings. But in case she's not responding, then of course we'll have to be going for a detailed imaging of the abdomen, as in to see if there is any deeper infection. And only when you see that she's getting any fever that is not responding to the initial treatment, probably will call for an inpatient admission, but otherwise it won't be required. But you need to make sure that anytime, at any point, you have to go in a non-blame manner. And this is about the postpartum voiding dysfunction, which is extremely important. And this can come in the form of an SPT, or it could come as a structured discussion. The woman is coming to you that she is not passed urine, or probably it can also be like, it could go in a sequential way where you'll be asked a series of questions by the examiner. So it's very important that you need to be aware about this algorithm. So make sure that you read all the pre-talk guidelines, at least the flowcharts, before you go for the exam. So in case the woman is unable to void, make sure that you have to put an in and out catheter assessment, and then we assess for the amount of the urine. So firstly, if it is less than 150 ml, obviously when it is less, probably it could indicate a dehydration. We don't know. So there is a reduced urine output. You need to evaluate the same. If it's between 150 to 250 ml, and you can ask her, because this is not very much, we ask her that once you remove the catheter, again you ask her to void after 6 hours, and then you can measure. And then if it is more than 700 ml, that is the other extreme, obviously it's going to be, you're going to put her for a longer time the catheter, because it's more than 700 ml. That means she should get the urge to pass urine, which she hasn't passed. So you have to put the catheter in situ and send her back home for at least 2 weeks or more. You ask her to put the catheter in situ. Now if it's anything in between that, then you can put the catheter, and then you can ask her to void after 24 hours. You can see the trial without using the catheter. You can do it in 24 hours, and then you could see the urine output. So this is something which is very, very important, that you need to be able to understand, as in how we'll be doing this, and how are we going to manage about the postpartum voiding dysfunction, which is extremely important. And it could come as a structured discussion as well. So make sure that you have to go through that guideline once again. So this module is very, very simple, and it's nothing very fancy, and it's all that we usually do on a day-to-day basis. But how well you're communicating with the patient, how sensitive you are, and how empathetic you are, how well you are allowing her to talk, or allowing her to react to whatever you say, and making that comfortable zone between you and role player is all the trick in this module, or for that matter in any module. So make sure that there are limited number of cases, not very much in this module. It's not very vast, and for a quick revision, it is definitely possible that you could be doing it in a day or two. So make sure that you go through this, and you also can go through the practice books wherein there are a lot of cases. And I hope this session was useful. In case you've got any doubts, you can let me know in the comment box below, and I'll be happy to help you all. So thank you guys, and please watch this video until the end, and also share with people who would be definitely benefited with this video. And I wish you all the very best for your upcoming exams, and I'll see you all in another one. And do not forget to like, share, and subscribe to our channel. Thank you.